Hello, my name is Dr. Peter Elkin, Professor and Chair of the Department of Biomedical Informatics at the University at Buffalo, and I'm pleased to represent my co-authors today in presenting our poster entitled Strokes Prevented, Biosurveillance of Non-Valvular AFib Patient Cohorts, CHA-2DS2-VASc and HAS-BLED Scores using Natural Language Processing and SNOMED CT. The study's been funded in part by Pfizer and in part by grants from the National Institutes of Health and the National Center for Advancing Translational Sciences, and the National Library of Medicine. Non-valvular atrial fibrillation, also known as NVAF in the U.S., is estimated to affect 5.8 million people, and those patients with non-valvular AFib have 5 times greater risk of stroke than those who do not. In this study, we examined the accuracy of traditional structured surveillance methods with a method that included the structured data plus incorporated data obtained from the clinical notes using natural language processing, or NLP. Both methods were compared to the gold standard generated by clinician review of the data. We conducted a supervised machine learning artificial intelligence 5-year retrospective electronic health record cohort study of patients age 18 to 90 with the diagnosis of non-valvular AFib. An electronic model using ICD-9 codes was used to generate the structured data set, and the machine learning algorithm was used to develop the model for querying the SNOMED CT codes, derived using natural language processing. These methods were used to identify the non-valvular AFib population, their CHA-2DS2-VASc, which gives you our stroke risk, and HAS-BLED score, or potential bleeding risk. A random sample of 300 patients were generated and reviewed independently by 2 clinicians. If there was disagreement, a third clinician reviewed the record to make a final decision for the gold standard cohort data. The data flow shown on the poster provides an overview of the patient flow from the large Allscripts EHR data that ultimately resulted in the study cohort. There were slightly over 96,600 patients identified with enough textual characters in clinical notes between the ages of 18 and 90. After conducting the electronic models and applying the inclusion and exclusion criteria, the ICD-9, or structured method, identified 1,849 patients with non-valvular AFib, and the NLP identified 2,722. All of the 1,849 from the structured method were also identified using the NLP process. Statistical analysis were done using RStudio. The sensitivity and specificity of the 2 groups compared with the gold standard and structured alone were assessed by the exact binomial, or the McNamara test, due to some small cell counts. Additionally, the area under the curve for the CHA-2DS2-VASc was calculated by the C statistic in Somers D using ordinal logistic regression. We used the U statistic to test rank correlation for paired samples, where U is approximately normally distributed, to determine if structured plus NLP is more concordant than structured data alone when compared to the gold standard. Our results showed that there were statistically significantly more patients identified in the population when the biosurveillance method included the SNOMED CT codes derived from the text using natural language processing were used to identify the non-valvular AFib cohort. This resulted in 32.1% more patients being identified in the structured plus NLP population than in the structured method alone. The sensitivity for the structured plus NLP method was also statistically superior to the structured data alone in determining the CHA-2DS2-VASc and HAS-BLED scores, with a difference in the sensitivity of 4% for the CHA-2DS2-VASc and the p-value equal to 0.002, and 42% difference in the sensitivity of the HAS-BLED with a p less than 0.001. The C statistic for the CHA-2DS2-VASc score was 0.864 for structured data and 0.914 for the structured plus NLP cohort, and the p-value comparing those two was less than 0.001. When compared with the gold standard, structured plus NLP, was shown to be more concordant than the structured data alone with respect to the CHA2DS2-VASc score, which had a z-statistic of 19.776 with a p-value of less than 0.001. Additionally, it was determined through clinician review that approximately 13.6% of the non-valvular AFib patients were untreated, yet met the criteria for anticoagulation treatment. If these results were extrapolated to the U.S. population, as seen in the table included in the poster, approximately 2 million additional non-valvular AFib patients could be identified by the structured plus NLP biosurveillance method, with an additional 1.2 million patients with no contraindications and a CHA2DS2-VASc score of greater than or equal to 2 who are currently not on treatment. The predicted population benefit by using the structured plus NLP method would result in a reduction of 48,000 strokes and 7,686 deaths, with a cost savings of over $3.2 billion to the country every year. The potential difference between the two surveillance methods could exceed $800 million per year. So in conclusion, structured plus NLP data extraction methods for biosurveillance of non-valvular AFib had a higher sensitivity than structured data alone when compared with clinician-established gold standard. Extrapolating these results nationally could lead to improvement in treatment rates that could result in fewer strokes and deaths in the non-valvular AFib patients nationally. Artificial intelligence-based biosurveillance informatics systems, as used in non-valvular AFib, have the potential to improve patient outcomes and save the healthcare system billions of dollars annually. Thank you for your interest in our work.